Good morning. We'll make a slow start. I've got a series of messages here to give you. Presenters have to encourage to keep on time. As I said, we have structured the session that there's a fair amount of time for discussion here, so I hope we can actually have an interactive session. The sessions apparently will be filmed, and the film's released on the SCTS University website. And apparently you can submit questions via anonymous submission to the moderators via the app. I think that's unlikely as I don't have the app, but so hopefully we can just do the old-fashioned things and people can put their hands up and stand up and make comments or questions. I've got an interesting session. We're going to try to cover current TAVI activity on both sides of the pond, and then take a look at new trials, new devices, and new indications for TAVI. First talk, the speakers have changed slightly in that Stuart Grant from Manchester is going to give the first talk and Mo Barber is going to give the valve-in-valve talk. Stuart's going to talk about a project that's been going for some time, which is a collaboration between the UK Cardiac Surgical Registry and the UK TAVI Registry as to what is happening with aortic valve intervention in the UK.
Thank you very much. So this talk will just be a brief overview of the UK TAVI registry and the UK Surgical AVR registry as over the past 5 years, up to the end of 2012. So we'll cover all TAVIs performed in the UK and also all aortic valve replacements with or without coronary artery surgery between January 2007 and December 2012. The databases cover all NHS hospitals within England and Wales and also include data from 4 private hospitals. The data undergoes a rigorous cleaning process and is regularly validated at unit level for accuracy. So in total, combined across the data sets, we had 46,438 unique records, which represented 46,049 patients. There were 367 patients who underwent more than one procedure during the time period and 11 patients who underwent 3 procedures during the time period. A number of those procedures were within the same hospital admission. They gave us 3,543 TAVIs and 42,895 surgical aortic valve replacements. The majority of those were isolated aortic valve replacements, and there were just over 18,000 aortic valve replacements plus coronary artery bypass grafts. This slide shows the annual TAVI volume in the UK. You can see how it's increased from just under 100 cases in 2007 to over 1,000 in 2012. The number of cases doubled from 2009 to 2012. This slide shows the annual surgical AVR volume over the time period, and the levels have remained stable at roughly 3,000 AVR and CABG cases and roughly 4,000 isolated aortic valve cases per year. This slide shows hospital volume for both surgical AVR and TAVI. Along the x-axis we have the total surgical AVR volume performed at each hospital, and on the y-axis we have the total TAVI volume. You can see on this slide that the proportion of proportion of aortic valve activity performed as TAVI varies significantly between hospitals. So I have a hospital out here which performs only 3% of their cases as TAVIs, and a hospital up here which performs around 30% of all aortic valve activity using TAVI. This slide shows the most contemporary data, again broken down for the 29 hospitals that perform in TAVI in the UK for 2012. The number of cases are performing over 80 procedures per year. This slide shows the age distribution of the patients undergoing the 3 different types of operation. So you can see how, although the age distributions is significantly different, there is a substantial overlap with regards to patient age for the patients undergoing either TAVI or surgical AVR. This slide shows the Logistic EuroSCORE distributions for the different surgical modalities. you can see how, again, the patients undergoing TAVI generally have much higher logistic EuroSCOREs than the patients undergoing surgical aortic valve replacement. However, there is an area of reasonable overlap between the groups. We'll now move on to some risk factor data in the different groups. We don't have the full gamut of risk factors for the EuroSCORE or EuroSCORE 2, but we do have some of them. This slide shows the operative urgency, the majority of cases across all groups being performed electively. Small number of emergency cases in each group. Slide shows the gender of patients undergoing the different procedures. Interestingly, approaching 50% of the patients undergoing TAVI are female. This slide represents the angina status of the patients undergoing the procedures. As would be expected, the patients undergoing isolated aortic valve surgery had very similar angina status preoperatively, whereas those undergoing aortic valve and coronary artery surgery had significantly more angina. With regards to dyspnea, the portion of patients undergoing TAVI had significantly more dyspnea than the patients undergoing surgical AVR. LV function again was worse for the patients undergoing TAVI. This slide shows the pooled overall in-hospital mortality, and this is for the 5-year period from 2007 to 2012. So over that period, the mortality for isolated surgical AVR was 2.1%. For surgical AVR plus coronary artery surgery was 4.2%, and for TAVI was 6.1%. This slide shows the in-hospital mortality broken down by year for TAVI. And then for the surgical AVR groups, with levels stable around 4% for AVR and grafts, with levels around 2% for isolated aortic valve replacement. This slide shows the post-operative length of stay for the patients undergoing the different procedures, with TAVI patients tending to go home earlier than the surgical patients. This is a survival curve for the different groups. So the blue dashed line represents isolated aortic valve replacement, the green dashed line is AVR and CABG, and the red line is TAVI. This is unadjusted and it's non-randomised data, so this is just to give a picture of the survival curves. And these are the midterm results from the UK data. So patients undergoing TAVI have a 30-day mortality rate of 93.8%. For AVR and graft, it's 96%, and isolated AVR 97.9%, with 5-year survival for patients undergoing TAVI of 41.6%, AVR and graft 74.6%, and isolated aortic valve replacement 82.6%. So to conclude, in the UK, we've seen a rapid increase in TAVI activity over the 5 years of 2007 to 2012. Surgical AVR activities remain relatively constant. There's significant variation in TAVI activity between centres, and the UK activities, UK outcomes for in the short and mid-term are good compared to the other published data.
Thank you very much, Stuart. Any questions for perhaps whilst you're waiting? TAVI is a very exciting area, but slightly sobering figure there that 60% of the patients have died by 5 years. It's a very expensive treatment for a third world country like ours. Do you think that's an acceptable mortality to be aiming for in this patient population?
Well, I think it's difficult because we obviously have the early TAVI procedures in there where the in-hospital mortality was significantly higher. So the in-hospital mortality over the last 2 years of the cohorts for TAVI was only 5%. So I suspect the survival will improve as time goes on.
Sasha.
Very nice talk. Have you seen any differences in regard to access, transapical, transaortic, or transfemoral?
We haven't specifically looked at that as part of this analysis, but we are planning to do that.
There's been some work on that as an isolated project from the UK registry, and I think the message that's coming out really is that the transapical and direct aortic routes have similar 30-day and 1 year mortalities, particularly at 1 year. Maybe transapical has a higher early mortality, but it would seem that patient population who can only be managed by direct aortic or transapical both have an impaired 1 year survival compared to those patients who can be treated by a transfemoral approach. But I think you made a comment. I think one of the interesting bits of information there is that the mortality, 30-day mortality in the last 2 to 3 years for TAVI is pretty much the same as all comers of patients having AVR and coronary artery surgery, which I think is an interesting observation, because we know almost half of the patients in the TAVI population have some degree of coronary artery disease, be it previous CABG, PCI, or documented coronary disease. So I think that's an interesting observation. Maybe one last question. I think one of the most striking slides you showed was the length of stay, where in conventional surgery, you really get nobody going home before day 7, whereas despite the TAVI population being older, greater comorbidities, there's a significant number of those going home before day 7.
Yeah, that's right, yeah.
Just a point about the skew on some of the comparisons, because the age distribution is different.
Yeah.
I think when you're looking at male-female differences, it'd be a good idea to try and find some way of relating that to the population, the underlying populations, because that'll produce a different picture, because there's a lot more women in older age groups than men. And I think with the mortality comparisons, these are not age standardized, are they?
Sorry, I didn't.
They're not age standardized, the mortality comparisons?
No, these are just crude mortality rates at the moment.
And again, because of the age skews, I think it would be worth trying to standardize the mortality rates by age.
Yeah. I mean, one approach to try and compare the two groups more accurately would be to look at a propensity-based analysis. But there is a question about whether we'd have enough power to do that,
sure,
because there's fundamental differences that aren't measured in the databases, which we may not be able to control through a propensity-matched analysis.
But I think they're good points in taking the work forwards is to do those stratifications. Stuart, thank you very much indeed.